Welcome to MedAxiom HeartTalk, where thought leaders come together for one ultimate goal: to continually transform cardiovascular care for all. MedAxiom HeartTalk starts now.
Hi, I'm Melanie Lawson, host of MedAxiom HeartTalk, and today we are discussing a case study: how guideline-directed medical therapy decreased CHF, congestive heart failure, mortality. So joining us today, we have Dr. Jeff Carstens, Cardiovascular Service Line Medical Director at UnityPoint Health, and also Sharese Van Sloten, Operations Director for the Cardiovascular Service Line, also at UnityPoint Health. Thank you all for joining us today. I love to kind of dig in and actually see how these combinations work, and specifically in this case, the drugs that we'll be talking about. So Dr. Carstens, let me ask, what struggles or issues was your practice facing that led you to look into making this change?
Yeah, so there are a number of things that we looked at. One was just how do you define heart failure, and coming up with a standard definition of heart failure, because there are different types of heart failure that require different types of treatment. And so making sure that we had a uniform definition. Also, there was a lot of variation in care across our organization, and quite frankly, we had issues with mortality. Patients were dying at a rate higher than what we would expect, and we needed to do a better job for our patients.
Yeah, and what changes did you make?
So we made a bunch of changes.
Okay.
But probably one of the major focuses was defining heart failure, having a standard definition, and then there is what we called guideline-directed medical therapy. Those therapies that are shown to be effective in reducing mortality, so death, hospitalizations, rehospitalizations for heart failure, and symptoms. And the American College of Cardiology, American Heart Association have a set of guidelines for how you treat heart failure. And the big goal was to get patients on as many of these drugs as possible. So there are 4 drugs or 4 classes of drugs for the most common type of heart failure with a weak heart, or heart failure with reduced ejection fraction. And our goal was to get those patients started on all 4 of those drugs, or as many drugs as they could tolerate during their hospitalization.
Because sometimes you were finding they were going home without any.
Sometimes the patients were going home on no drugs, and I want to be fair to UnityPoint. That's not unusual.
Okay,
That's common across the United States when we do studies, or when they do studies and look at this stuff. It's surprisingly common that the patients go home on no drugs, but as many as 20%, or 1 in 5 of our patients hospitalized with heart failure were going home on none of those guideline-directed drugs.
Sharese, I want to bring you into the conversation. So can you share more about the process improvement tool you utilized, and also the data that it provided?
Absolutely. So we had an opportunity to really engage our team members, our clinicians, our physicians across the whole entire organization to really bring them together to think this through. And we used a framework where we had a brainstorming session up front. We had close to, I would say, 80 to 100 people there, and everybody had an opportunity to participate and have their voice heard. And I think that was critical for our organization, for the people who are taking care of these patients, to be in a position to help support change and help support process improvement. From there, we took an approach where it was really, we need to first diagnose what the problem is, like the doctors do, and we need to then design solutions to help support improving those problems. From there, we went into delivery mode and partnered with our IT team, partnered with analytics to really make these solutions come to life in a meaningful way for our teams, but then more importantly for our patients. That took quite a few months, and we are still in the phase of monitoring how did the implementation of those initiatives really impact our patients. And we've got a set of metrics that everybody is aligned and working towards improving, and we're really seeing the impact, especially with the GDMT within our patient population, and how that's helping support their care.
Yeah, I love that you had so many people involved in that first conversation, because that brings that buy-in, right?
Absolutely, and they're still bought in. We just had a meeting last week where we brought the team that's been involved all throughout the process back together. We had 80 some people in attendance at that, and active conversations. we have multiple different markets, and they had a chance to ask, hey, what's going well for you? Here's an area of opportunity we've identified, and just helping support one another do the right thing for their patients.
Yeah, you probably rarely get that opportunity to have that many people in the room.
It was, yes, it's a virtual room, right?
I was gonna say, how long was that meeting?
It was, we're across, quite geography across the state, and brought them together virtually, and just the engagement even on a virtual meeting like that, it was pretty impressive, and you've got the right people involved.
For sure. All right, let me ask either one of you this question or both. Do you see the strategic process improvement model as something expandable in other areas of CV as well?
Yeah, absolutely. I mean, and getting people engaged, getting people that are interested in a problem, helping to define the problem, helping to solve the problem. That could be applied to virtually any cardiovascular problem. So atrial fibrillation will be our next area that we'll be approaching later this year. Our organization uses this clinical effectiveness project for a number of things. So they've tackled sepsis, they've tackled maternal hypertension, they've tackled behavioral issues and those types of things. So the service lines get their turns. Our turn's coming back up again, hopefully later this year, and we'll be looking at atrial fibrillation, which is another huge problem in cardiology.
Right, no doubt.
And even within our service line, we have a very strong program manager who's taken the concept of our clinical effectiveness team and really applied it to much smaller projects, but really keeping that process improvement mentality at the forefront for our teams to address even small quick wins as well.
It's exciting. Future looks bright.
It does,
right.
yes.
Dr. Carstens, Sharese, thank you all so much for joining us on this episode of Heart Talk.
Absolutely.
Thank you.
Thank you for the opportunity.